All right, we'll go ahead and get started. So hi everybody, my name is Jefrey Heiferman. I'm the current simulation fellow at Loyola University Medical Center, and today I'm going to be talking a little bit about Gestalt. I have no financial disclosures. So first, I want to just take you guys back to a time when you were learning how to ride a bike. You don't really know what you're about to do. You know you're going to sit on a bike. You know you're going to go somewhere, but you don't know how to do it. And some of the people in the room have probably been on the other side of that, trying to teach somebody how to ride a bike. And being able to tell somebody, okay, well, little kid, I'm assuming that's who you'd be teaching, little kid, go ahead and sit on the bike, and then go ahead and put your hands on the handlebar, sit on the seat, and then go fast and don't fall, and while you're doing it, be aware of your surroundings, don't hit anybody, don't hit anything, and there's so many more things to it that are just hard to describe. And so today I want to talk about giving that Gestalt, giving that gut feeling that's just so difficult to teach your learners, to describe to others. I'm going to give 4 tips today on how to do that. So explicit knowledge is the thing that you see. So whenever we're talking with our learners, whenever we're describing concepts, we're usually going over explicit knowledge. It's usually testable content, it's usually management styles, it's usually diagnostic abilities. But then that gut feeling, that Gestalt, is somewhere underneath. So it's all of our experiences, it's our roots, it's what grounds us, and it's just the ideas that sort of bring us to where we're at. And these ideas and experiences are often hard to describe in a more tangible way. So now to bring it more into a clinical context. So I want you to think of the first time that you were in an emergency department. So often for many of us, it was the first time that we were shadowing in the ER, when you sat next to an attending who the ambulance bay doors open, a patient's rolling out, and there's a patient who's short of breath, and they go, oh, that's a STEMI, or oh, CHF exacerbation. And a lot of us in clinical practice now have that ability. We can be able to predict those things, and if somebody were to ask you, how do you know that? You know, you can describe bits and pieces of it, but to really get your learner to that another level, to bring them to understand a whole concept and get a grasp on, this style of thinking is much more difficult than it is to just describe something more tangible. So I have 4 different frameworks that I want to talk about, 4 approaches that you can take to describing this Gestalt, or in order to deliver your framework onto your learners when going through these difficult topics. And something that I wanted to go over were specific examples too. So we'll go over some specific examples and when each of these different frameworks can be used. So first we'll talk about scaling it down. So this is an example. I was actually working on shift with an educator, and this educator is somebody who's respected, and I remember specifically hearing the delivery of this information that this was the educator on to the student, and this person said, the lactate is 4, the patient is sick. And I remember the student just sort of stood there and said, oh, okay, patient's sick, lactate's 4, I get it. And the lactate is one of my favorite things to sort of, I don't quiz students, but to ask students about and to just sort of gauge their knowledge of lactate, because when we hear a lactate, when we've been through it before, we've seen so many lactates, when somebody tells us what a lactate is, we have an idea of how nervous we are or how comfortable we are. And being able to understand that is something that we have gained through all of our experiences, and something that new learners, if they hear a single number, they really don't know everything that comes with that. So I always try and scale it down. So I talk with the learner, and I say, okay, we have a value here. And in order to transfer your knowledge base to the learner, you want to be able to describe, what is going on in terms of where does this number lie. So you want to describe 2 extremes whenever you're describing this new value. So for instance, lactate is 4. And now you want to describe 2 alternate scenarios. What if the lactate were 2? You say lactate 4, the patient is kind of sick. Well, make sure that they know that a lactate of 2 means, minimally sick, sort of on the verge. And then, if you're going up to these 8, 9, 10 values, that patient is really, really sick. And for us, when we first described just saying a lactate of 4, the patient's sick, we assume that the student's understanding, oh, okay, they have a concept of what a 4 means. But until you really lay out a full framework, they really don't grasp that concept. And then moving one step forward, whenever I'm describing this scale, I always make sure to describe how often these things are happening. Because in order for them to understand where you're coming from, we know how often we see these things. We know how often patients are sick, how often patients aren't sick. When the lactates come back, we can often predict what they're going to be based on our Gestalt. Not always, but very often. And so being able to describe these things, just say, hey, every day we see patients, because in our electronic medical record, when a lactate comes back at 2, that's a red flag for us. And for us, we sort of shrug that off to some extent. So just being able to describe, hey, this happens all the time, it's nothing to worry about. And then you go up to these higher lactates, and being able to describe, hey, like this doesn't happen very often. This is a once a week, once a month occurrence. And you just you pass along your Gestalt to them, that they finally get thinking about, hey, what does this mean in context? And this idea, you might think, oh, this can't be used very often. Okay, I can describe a white blood cell count, I can describe a lactate, but then you can encode this scale to words as well. So you can translate these numbers into descriptions. So another example, talking about a patient coming in short of breath. Again, this patient's short of breath, they're sick, and to a new learner, for a medical student, they may have seen their friend who ran a marathon and they're short of breath. They've seen that, and their other context is this patient in front of you. So they don't have a grasp of what it looks like. And us who've seen so many patients, we have an idea of what sick is and what not sick is. So just to give them one time point, I think is not really passing along your knowledge to them. So again, just being able to describe it on a scale. So starting with shortness of breath, saying, hey, this patient's able to speak 2 words. Let's throw 2 extremes in there. They're not speaking full sentences, but at the same time, they're not tripoding, they're not altered. So being able to describe the 2 extremes really puts it into a better context. And then let's say it's an asthma exacerbation. Say, hey, we see 2 patients a day who need, just a neb, they can go home. The 2 words we see every week. And then somebody who's on the verge of intubation, we just see that a few times a year. And when you describe those frequencies, now the learner really gets a sense of, how do patients present to the emergency department with shortness of breath? And it's just a bigger context. And your Gestalt that you've seen so many times, you're able to package that all up nicely and deliver it to the student. So the next concept I wanted to discuss was train of thought. So train of thought is exactly what it sounds like. And I think train of thought is an interesting idea in that we use train of thought not to describe things to our learners, but we use it the other way around. So whenever we're working with a new learner, let's say a new intern, it's their first intubation, the standard is to say, hey, you're going to be on this airway, you're going to go ahead and do this intubation, but what I need for you to do to make sure this is safe is tell me everything that's going through your mind. So you're going to go ahead and take the airway, you're going to look and tell me what you see and tell me what you're doing, tell me your next steps, tell me your backup plan. And really only by having the learner tell the teacher what's going on, that's the only way that we can entrust them. We can understand what is going through their head. And that concept is great when you are trying to manage your learner and make sure you're doing it in a safe way. But then if you can reverse that role, it can be that much more helpful for the learner. So this is a tough one in that your senior residents, if you're working with senior residents, don't want to hear your whole train of thought. So this is more for an early level learner, but the times when I'll use it will be for procedures. So if let's say if I'm doing an airway with a medical student alongside me, I'll go ahead and describe those things. So I'll sit there and talk out loud as I'm going so that they can listen to me, hear what's going on through my head, hear my thought process, hear the different things that can go wrong, and then they can understand those things to really get a better sense of what should I be thinking about when I go into that situation. And so it's helpful for procedures, but then also on the other side, it's helpful for resuscitation. So I do this most often when there's a senior resident and they're running the resuscitation. I'll stand on the side with, again, an earlier learner, and I just narrate what's going on. And I think doing this is helpful for the learner, and they always just show appreciation because they're the medical students, when they walk into a room, They don't know what's going on. They don't know that ABCs are happening and medications and IV access and the 30 things that are happening all at once, and all the different differentials that are going through our head, management styles. We're already thinking about dispo early on. Those kind of things, as I describe them quickly, you come to realize how many things you're thinking about when the patient arrives, and the student's probably standing there saying, oh, okay, like we have to do something. Oh, okay, they're starting a nebulizer. So they're thinking one step at a time, but we're thinking about so many complex situations, so many complex management styles and pathways that it's important for us to be able to pass that Gestalt along. And all the thoughts that are happening in our mind shouldn't stay silent. They should be coming out and be given to the learner, and then they can learn so much more. So next, I want to talk about gut feeling statistics, which is exactly as it sounds like. It's really a method to talk about what your predictions are for the case. And so I think going back and giving your train of thought is helpful, and currently what's going on, currently the management of the patient. But this is really thinking forward and being able to describe what is going on next. And so this is something that I like to do, and something that I give with an asterisk, because gut feeling statistics, I say, hey, I always preface the learner, I say, hey, this is just based on my thinking, my Gestalt, what I've been through, and I think there's a 30% chance this patient's gonna go home, 10% chance this patient's gonna be admitted to the floor, and I can't add up to 100, but a 5% chance that the patient's going to be admitted to the ICU. And in doing that, you're sort of just taking your Gestalt, again, your Gestalt is what you've been through before, and using that to predict what you're gonna be doing in the future, and you're just physically passing that information along to your learner. I say this again with an asterisk, because whenever you're doing this, you're starting to bring in some bias, and that is always something that you need to be cautious of. So I give a lecture to the third-year medical student class about implicit bias and just using how bias can be helpful, but again, it can be very, very harmful. So whenever you're doing this, you're obviously bringing in your past experiences, which also brings in your judgments. So just being aware of that, and that's why I always preface the learner, hey, this is not based on a textbook, this is based on what I've seen before, and just being able to pass that information along, but then being really cautious that they just know that this isn't, don't take whatever I'm about to say with a grain of salt. But again, bias, it can be harmful, absolutely, but at times, bias can be helpful to bring you to a conclusion more quickly, probably less accurately at times, but it can be helpful. So I like to, again, pass this along just with that asterisk on it. And finally, just describing, we'll go over frame it. So a patient comes in DKA, there's a lot going on with them. When they arrive, again, our Gestalt has a ton of things going on. We're starting to think about resuscitation. We're thinking about their glucose level, how big their gap is, where that potassium level's at. Do we start a drip? Do we just give fluids? There's just so many things that we're thinking about when that patient arrives. And to us, it's relatively simple. Do any of those things and you're doing it right. But for a new learner, it's really difficult to understand all the different things that are going on, and being able to frame what you're doing to their context can be helpful. So this method, especially the example that I'm going to give, is doing this with a really early learner. So I've had first and second year medical students shadow me, and their clinical context is almost zero most of the time, where their full-time schedule is sitting there studying biochemistry, studying cell biology, and they haven't even seen a patient. They don't know how to talk to patients yet. So being able to really connect with them is that much more difficult, I feel like. You work with the third and fourth year medical students, and they understand what a patient looks like. They know, they just get it a little bit. They're starting to get it, I should say. But these really early learners are difficult to connect with. So first, just organizing your thoughts and organizing sort of the pathophysiology of the case, I think, is important. So again, once you're able to take this mess of Legos and put it into its specific parts, you're able to better connect with your learner. So just understanding where they're coming from. I've heard people talk about just complex topics with these students, and no matter what, they're gonna say, oh, I understand. They're gonna smile and nod because they just want to look good. You know, they don't want to show that they don't know what you're talking about. And so being able to connect with them, you know, when you're talking about DKA, you know, talk about the cell biology, to talk about those sodium potassium transporters, talk about the insulin and how it's going to push the glucose into the cells, and those kind of things they see day to day and they learn about. And if you start talking about, you know, resuscitation and fluid boluses, they probably haven't heard the word bolus. You know, they just don't know those concepts yet. So if you start talking in those contexts, it'll go over their head. So I always just start with the foundational knowledge that I know that they study on a day-to-day basis, and just being able to bring it down to their level and then build on that. But until you do this, if you don't start with this foundational knowledge, I think a lot of it will go over their head. So again, the 4 concepts that we talked about today can all be helpful for giving your Gestalt, passing that gut feeling onto your learners. Don't forget to scale it down. So again, that's making a framework, making a scale for your learners, and talking about how often each of your cases is landing on that scale to help them understand the severity of the patient in front of you. Talking about your train of thought. So again, that's just saying what you see and saying what you're thinking about to the learner. Your gut feeling statistics. Again, you need to be cautious and take this one with a grain of salt, but you want to say, hey, you know, what % chance are the next predictive things going to happen? And because that's what we're thinking about when the patient hits the door, so it's important to transfer that on to our learners. And then finally, framing it, being able to talk at the level of your learner and connecting it to their foundational knowledge, and not just jumping ahead and talking about bigger resuscitation and the more difficult topics that we talk about in the emergency department. So if you're able to do those things, you're a little bit better able to pass along your Gestalt. Then your learner can get on that Gestalt bike and ride it to the finish line. So thank you. Any questions or ideas or, you know, topics, cases that you wanted to ask about or anything like that? And no is an okay answer as well. All right. Well, thank you.